Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 436 of our pharmacotherapy series, which majors in breast cancer. This video discusses the case of CDC from parts 434 and 435 of this pharmacotherapy series. CDC is to undergo 4 cycles of AC chemotherapy followed by weekly paclitaxel for 12 weeks. So my questions to you read: what are the common toxicities associated with this treatment course? If the tumor was HER2 positive and CDC received trastuzumab, what toxicities would be associated with its use? Doxorubicin is an anthracycline chemotherapy agent. It works through multiple mechanisms, but inhibition of topoisomerase II may be most important. By inhibiting this enzyme, double-strand DNA breaks occur. Common toxicities include myelosuppression, nausea or vomiting, and alopecia. A well-known toxicity of anthracyclines is the risk of cardiomyopathy due to the formation of oxygen-free radicals and doxorubicin metal complexes. These toxicities can be acute, with symptoms similar to an arrhythmia or myocardial infarction, or chronic, with a patient demonstrating symptoms of congestive heart failure. The risk of cardiotoxicity increases with larger anthracycline cumulative doses. With the typical doses of anthracyclines used in the adjuvant setting, a patient will not reach the cumulative doses known to increase the risk of cardiotoxicity. If a patient has underlying cardiac dysfunction, baseline evaluation of ejection fraction through either an echocardiogram or a multi-gated acquisition scan should be completed. Other known risk factors for the development of anthracycline-induced cardiotoxicity include age older than 70 years, hypertension, pre-existing coronary artery disease, and previous cardiac irradiation or anthracycline exposure, which may warrant cardiac evaluation. Cyclophosphamide is an alkylating agent that works by forming cross-links in DNA, thus inhibiting DNA synthesis. Common toxicities are nausea or vomiting, myelosuppression, and alopecia. The alkylating agents, although rare, are also associated with a risk of secondary leukemias. Paclitaxel, a taxane chemotherapy derived from the Pacific yew tree, works by binding to the beta-tubulin subunit of microtubules, preventing disassembly and ultimately causing inhibition of mitosis. Common toxicities associated with paclitaxel include nausea or vomiting, myelosuppression, neuropathy, and hypersensitivity reactions due to the modified polyoxyethylated castor oil, chroma-4-EL, solvent in paclitaxel. All patients should be pre-medicated with dexamethasone and H1 and H2 blockers to prevent hypersensitivity. Trastuzumab is a monoclonal antibody targeted against the extracellular HER2 protein. The classic toxicity associated with trastuzumab is cardiac toxicity, but is different from that with anthracyclines. Trastuzumab cardiotoxicity is considered reversible and believed to be a result of HER2 blockade. That is, HER2 signaling is responsible for cardiomyocyte growth, repair, and survival. In those patients who will receive long-term trastuzumab therapy, baseline cardiac function should be evaluated similar to doxorubicin and then periodically with echocardiogram or a multi-gated acquisition scan during therapy. CDC does not have a history of cardiac disease, so a baseline cardiac evaluation before AC therapy may not occur. CDC should be counseled on the common toxicities associated with her chemotherapy, such as myelosuppression, nausea or vomiting, alopecia, neuropathy, cardiomyopathy, and hypersensitivity reactions. After the completion of her adjuvant chemotherapy, CDC will receive hormonal therapy because her disease is estrogen receptor progesterone receptor positive. So my questions to you read: what are the common adjuvant hormonal regimens used? What regimen would be appropriate for CDC? Breast cancer is a hormonally mediated disease, and therapies that alter hormonal levels are an integral component to the treatment plan. This therapy is offered to patients with estrogen receptor and/or progesterone receptor positive disease. Therapeutic options include selective estrogen receptor modulators, luteinizing hormone-releasing hormone, abbreviated as LHRH, agonists, and ASH. Menopausal status of the patient is used to help guide selection of therapy. Traditionally, tamoxifen has been the gold standard for adjuvant hormonal therapy. Tamoxifen is a selective estrogen receptor modulator, which works by blocking estrogen from binding to the estrogen receptor. It does not alter estrogen production. Tamoxifen has antiestrogenic activity in the breast, although it has estrogenic effects in other areas such as bone. Tamoxifen can be used in both premenopausal and postmenopausal women and is given 20 mg orally daily for 5 years based on the data from the National Surgical Adjuvant Breast and Bowel Project B14 trial. Tamoxifen should be initiated after chemotherapy because it can antagonize the anti-tumor activity of chemotherapy if given concurrently. Common toxicities associated with therapy are hot flashes and vaginal discharge. More thrombosis, pulmonary embolisms, and strokes can occur in patients older than 50 years of age receiving tamoxifen compared to placebo. Risk ratio 1.6, 3.19, and 1.59, respectively. Ovarian suppression is an alternative therapy for premenopausal patients because the ovaries are the largest source of estrogen. This is typically achieved through the use of luteinizing hormone-releasing hormone agonists. Surgery or radiation can also induce ovarian ablation. However, surgery is irreversible and offers an immediate effect, whereas radiation may offer an incomplete response and slower onset. If a woman would like to maintain fertility throughout chemotherapy, a thorough discussion with her physician should occur. Studies with the use of luteinizing hormone-releasing hormone agents have been tested as a means to preserve fertility, but have shown mixed results. Combination data with a luteinizing hormone-releasing hormone agonist with tamoxifen have not shown significantly better outcomes than each modality alone. Postmenopausal patients also have the option of aromatase inhibitor therapy. Aromatase inhibitors inhibit the production of estrogen by preventing the conversion of androstenedione and testosterone to estrone and estradiol. There are two classes of agents: non-steroidal aromatase inhibitors, anastrozole and letrozole, and the steroidal aromatase inhibitor, exemestane. These agents are highly selective for the aromatase enzyme and have less toxicity than tamoxifen and other hormonal agents. Aromatase inhibitors should only be used in postmenopausal women. If used in the premenopausal setting, initial surges of estrogen occur due to the body's compensation mechanisms, i.e., hypothalamic pituitary axis, and negative feedback loop. If used as single therapy, aromatase inhibitors are given for 5 years. The optimal hormonal therapy regimen for the adjuvant setting has not been identified. In premenopausal women, the options are 5 years of tamoxifen therapy plus or minus ovarian suppression with a luteinizing hormone-releasing hormone agonist. If the patient continues to be premenopausal at the end of 5 years of adjuvant tamoxifen therapy, the patient may consider 5 additional years of therapy. There are conflicting data to support this recommendation. Based on newer data, the American Society of Clinical Oncology published an updated practice guideline for adjuvant hormonal therapy. If, after 2 to 3 years, the patient becomes postmenopausal, then 2 to 3 years of an aromatase inhibitor may be given to complete a total of 5 years of therapy. If the patient is postmenopausal at the beginning of adjuvant hormonal therapy, an option would be to take an aromatase inhibitor for 5 years. There have been no prospective comparisons of the aromatase inhibitors with each other. Therefore, any can be used as first-line treatment. Another clinical option is 5 years of tamoxifen, and, if the patient is postmenopausal after the end of 5 years, an additional 5 years of an aromatase inhibitor can be given. This was found to be beneficial in an extended study of hormonal therapy. At the 2.4-year follow-up, additional letrozole therapy was associated with a superior 4-year disease-free survival, 93% with extended letrozole versus 87% in the tamoxifen arm, with a p-value less than 0.001. However, in the 8.1-year follow-up data, the additional letrozole therapy did not improve outcomes compared with letrozole monotherapy in terms of disease-free and overall survival. Each individual's length of therapy should be determined based on the patient's risk of recurrence and their ability to tolerate therapy. CDC is premenopausal, so she would start with tamoxifen therapy. If after 2 to 3 years of therapy, CDC becomes postmenopausal, she could continue the tamoxifen for a total of 5 years or convert to an aromatase inhibitor to complete a total of 5 years of therapy, then continuing the aromatase inhibitor for an additional 5 years. Because of her age, she will likely continue to be premenopausal after chemotherapy and be maintained on tamoxifen for 5 years. If she remains premenopausal, she should have a discussion with her physician on the merits of continuing tamoxifen for a total of 10 years. If she completes 5 years of tamoxifen therapy and is postmenopausal at that time, then extended use of an aromatase inhibitor for an additional 5 years would be recommended. At this time, Ovarian suppression with a luteinizing hormone-releasing hormone agonist could also be added because she is premenopausal to chemically suppress her ovarian function. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 437.